In this lecture, I will introduce you to the occlusion and trauma from occlusion. So please listen carefully and understand this lecture. It's a very important lecture in periodontal subject. Here, occlusion, what do we mean by occlusion? Occlusion is simply the contact between teeth. More technically, it is the relationship between the maxillary and the mandible teeth when they approach each other as occurs during chewing. And this is the occlusion, the contact between teeth. Malocclusion is misalignment of teeth and jaws, or more simply, a bad tape, a bad bite. It is a malalignment of teeth and jaws and bad bite. Malocclusion can cause a number of health and dental problems. Malocclusion can cause dental and health problems. Static occlusion refers to contact between teeth when the jaw is closed and stationary, while dynamic occlusion refers to the occlusal contact made when the jaw is moving. Dynamic occlusion is also termed as articulation. Now, what is the difference? I will ask this question: what is the difference between static and dynamic occlusion? The static occlusion refers to contact between teeth when the jaw is closed and stationary, while dynamic occlusion refers to the occlusal contacts made when the jaws are moving. Dynamic occlusion is also termed as articulation. And in my personal opinion, the dynamic occlusion is bad, while the static occlusion is good, because the dynamic occlusion is while the jaw is moving. We can see here, you can see here, as you can articulate it with your mouth. If you can do it, if you can do a dynamic occlusion, then this is a bad thing, because it will make your occlusion happens before it is stationary, and that is not good. There is also the centric occlusion, is the occlusion of opposing teeth when the mandible is in centric relation. Centric occlusion is the first tooth contact and may or may not coincide with maximum intercuspation. The centric relation is a relationship between the maxilla and mandible. We have studied the centric occlusion and centric relation. The centric occlusion is the occlusion of opposing teeth when the mandible is in centric relation. Centric occlusion is the first tooth contact and may or may not coincide with maximum intercuspation. Intercuspation, and it is very well known thing, the maximum intercuspation. The centric relation between the maxilla and mandible. And the centric relation is a wider definition than the centric occlusion. I will complete, so please understand me and listen carefully. Assessing occlusion. How to assess occlusion? We have extraoral assessment that is done to check for facial asymmetry and skeletal discrepancies, and to measure the lower face height. Loss of teeth and occlusal stops can result in overclosure, causing a reduced face height. Overclosure is unlikely for patients with tooth wear due to dentinoalveolar compensation. Dentinoalveolar compensation. Over-eruption may occur for patients due to the dentinoalveolar development in absence of tooth wear, which may result in increased face height. So increased face height can be caused by over-eruption that occurs for the patient due to dentinoalveolar development in the absence of wearing of the teeth. And somebody is questioning when it is happening that the overclosure. The overclosure is unlikely for patients with tooth wear because the dentinoalveolar compensation, and this will come in the test. Such question: why the overclosure is unlikely with patients with the tooth wear? And the answer is the overclosure is unlikely for patients with tooth wear because of the dentinoalveolar compensation, the dentine compensation and the alveolar bone compensation that's happening for the patient with tooth wear. But the over-eruption can happen and can occur for patients with dentinoalveolar development and abscess of tooth wear, which may result in increased face height. Loss of teeth and occlusal stops can result in overclosure. So such question can happen in the tests. Three options for overclosure. One of them is not likely to cause overclosure. Number one, loss of teeth. Number two is tooth wear, and number three is occlusal stops. Which one is not gonna cause the overclosure? And the answer is tooth wear, because the tooth loss and the occlusal stops. What is the meaning for occlusal stops? We will discuss that maybe, but now let's know that occlusal stops and tooth wear will cause overclosure, and over-eruption can be caused by overgrowth of the dentinoalveolar development, which increase face height. Now moving on, the temporomandibular joint is also can be assessed after checking the asymmetry of the skeletal and the skeletal discrepancy, and after measuring the face height, overclosure, over-eruption. And the temporomandibular joint is one type of assessing the extraoral assessment of the occlusion. The temporomandibular joint is the maximum extent, and the maximum extent the patient can open is measured between the incisal edge of the upper and lower incisor. Deviation of the mandible on opening or closing should be described. Clicking, cryptus and tenderness of the jaws should be noted as well. Clicking, cryptus and tenderness of the jaws should be also noted. This is also a part of extraoral examination of the occlusion is the temporomandibular joint after measuring the face height and measuring the asymmetry and skeletal discrepancy. The intraoral assessment it's combined of intercuspal position, ICP, centric position, and retruded contact position, terminal hinge, axis position, excessive movements of mandible, which include protrusion and lateral extrusion. Again, intraoral assessment consisting of intercuspal position and which is also called centric position, and the retruded contact position, RCP, termed also the term used for retruded contact position is the terminal hinge axis position, and excessive movements of the mandible, which include protrusion and lateral extrusion. Trauma from occlusion. This is another subject I will discuss to you. The trauma from occlusion. It's a term used to describe pathological alterations or adaptive changes which develop in the periodontium as a result of underforce produced by the masticatory muscles. Again, trauma from occlusion is a term used to describe pathological alterations or adaptive changes which develop in the periodontium as a result of undue force produced by the masticatory muscles. Again, trauma from occlusion is a term used to describe pathologic alterations or adaptive changes which develop in the periodontium as a result adaptive change which develop in the periodontium as a result of underforce produced of force produced by the masticatory muscles. Trauma from occlusion, this is happening by the masticatory muscles and is only one of many terms that have been used to describe such alterations in the periodontium. Is a trauma from occlusion. One of many terms have been described to such alterations in the periodontium. Other terms often used are traumatizing occlusion, just like trauma from occlusion, and it is also, of course, as pathological alterations or adaptive changes which develop in the periodontium as a result of or under force produced by the masticatory muscles. Trauma from occlusion is only one of the most of many terms that have been used to describe such alteration in the periodontium. Other terms often used are traumatizing occlusion, occlusal trauma, traumatogenic occlusion, periodontial traumatism, overload also is used as a term to describe trauma from occlusion. In addition to producing damage in the periodontal tissues, excessive occlusal force may also cause injury, for example, the temporomandibular joint, the masticatory muscles, causing painful spasm, or may cause excessive tooth wear. Again, I will repeat this. Other terms are used, and we have also mentioned, like overload, to produce damage in the periodontal tissue. Excessive occlusal force may also cause injury in, for example, number one, temporomandibular joint, number two, masticatory muscles, number three, excessive tooth wear. Okay, tooth wear, masticatory muscles, temporomandibular joint, and pain, spasm, masticatory muscles, and all of this are happening from trauma from occlusion. Traumatizing forces may act on an individual tooth or on groups of teeth. In a premature contact relationship, may occur in conjunction with parafunctions such as clenching and bruxism. The trauma from occlusion can happen with a conjunction with parafunctions such as clenching and bruxism. In adjunct with the loss of or migration of premolar and molar teeth with an accompanying gradually developing spread of the anterior teeth or the maxilla. All of these are happening with the parafunctions or clenching in conjunction with the loss or migration of premolar and molar teeth with an accompanying gradual developing spread of anterior teeth or the maxilla. This is the traumatizing force that it's an individual tooth or groups of teeth. Premature contact may occur during parafunctions such as clenching and bruxism. This is a question: what is the main causes of trauma of occlusion? And the answer will be number one, bruxism; number two, clenching. I will also talk to you about acute and chronic trauma. Starting with acute trauma, results from an abrupt occlusal impact such as biting on a hard object, abrupt like sudden occlusal trauma, biting on hard subject, restoration or prosthetic appliance that interfere with or alter the direction of occlusal force. All of these are trauma from occlusion, acute trauma, not chronic, acute trauma. And it's happening by biting on restoration prosthesis or appliance that interfere with the direction of occlusal force. Also biting on a hard object. Acute trauma results in tooth mobility, sensitivity to percussion, and increased tooth mobility. Again, mobility, sensitivity to percussion, and mobility also we have mentioned. Mobility and sensitivity to percussion. If the force is dissipated by a shift in the position of the tooth or by wearing away or correction of the restoration, the force is dissipated by a shift in the position of the tooth by wearing away or correction of the restoration, the injury heals and the symptoms subsides. Otherwise, periodontal injury may worsen and develop into necrosis. accompanying by periodontal abscess formation, or may persist as a symptom-free chronic condition. Acute trauma can also produce cementum tears. So there are many prognosis, and many going to happen, many things going to happen after occlusal sudden trauma, acute trauma. Number one, may worsen and develop into necrosis. Periodontal injury may worsen and develop into necrosis, and accompanying by periodontal abscess formation. Again, periodontal abscess formation, periodontitis, acute periodontitis, acute pulpitis or abscess formation, and may worsen and develop into necrosis, pulp necrosis, periodontal abscess formation, or cause chronic condition and produce cementum tears. Then I will also have to ask you this question, and you have to answer it with 4 points. What are the causes and what are the sequence of causing an acute trauma of occlusion? The answer will be number 1, acute trauma from occlusion causes number 1, cementum tears. Number 2, periodontal abscess. Number 3, periodontal injury. Number 4 is acute pulpitis, and number 4 may develop into chronic condition or chronic trauma, chronic occlusal trauma. Or number 5 is the necrosis, pulp necrosis. Now, to leave the acute trauma and go to the chronic trauma. Chronic trauma is more common than acute for acute form and is of a greater clinical significance. This is the question sometimes people ask, which one is the most important? Chronic or acute occlusal trauma? The answer is chronic occlusal trauma. It's more clinically significant, and it most often develops from a gradual change in occlusion produced by tooth wear, drifting movements, or extrusion of tooth combined with parafunctional habits such as bruxism and clinching, rather than as a sequel of acute periodontal trauma. So it does not come from acute periodontal trauma, but from gradual change in occlusion produced by tooth wear, drifting movement, or extraction of teeth combined with parafunctional habits such as bruxism and clinching. We already mentioned bruxism and clinching, and tooth wear, drifting, extrusion of teeth, not extraction of teeth, extrusion of teeth with parafunctional habits such as bruxism and clinching, rather than a sequel of acute periodontal trauma. So it can be a sequel of acute periodontal trauma, but it is most likely happening from the other reasons, like clinching, gradual change in occlusion produced by tooth wear, drifting, extrusion of teeth, etc. And this is the chronic trauma that we have said. I will repeat. There is acute trauma that's happening. That's sensitive to percussion and causes tooth mobility, and causes many other symptoms that we have mentioned before. Then we have the trauma from occlusion. We have also mentioned assessing the occlusion from extraoral and intraoral. Then we have studied occlusion and malocclusion and hemiocclusion, static occlusion, centric relation, and centric occlusion. Let's move on. After chronic trauma, we have the physiologically normal occlusion phase forces in chewing and swallowing. Small, rarely exceed 5 Newton. They provide the positive stimulus to maintaining the periodontium and the alveolar bone in healthy and functional condition. So, in physiological normal occlusal forces, what is the physiological normal occlusal forces? It is in chewing and swallowing. Small and rarely exceeds 5 Newton, and they provide positive stimulus to maintain the periodontium and the alveolar bone in a healthy and functional condition. The impact force, after we have studied physiological normal occlusal forces, we have to now study the impact forces, mainly high but of short duration. The periodontium can sustain high forces during a short period. However, forces exceeding the viscoelasticity buffer capacity of the periodontium ligament will result in fracture of tooth and bone. Also, there is a continuous force and a very low forces, for example, orthodontic forces, but continuously applied in one direction, are effective in displacing a tooth by remodeling the alveolus. Forces in one direction, orthodontic forces, bodily or tipping forces, produce distinct zones of pressure and tension, and we don't have to know which one is the tension one, which one is the pressure one, because it's very obvious. We have studied orthodontic, and we now have studied what is a continuous force and how is a low grade force is important. What is the meaning of jiggling force? Jiggling force is intermittent forces in two different directions. Premature contact on, for example, crown filling. This causes jiggling force, result in widening of the alveolus and in increased mobility. Under the forces of occlusion, a tooth rotates around a fulcrum or axis of rotation, which is in single rooted teeth is located in the junction between the middle third and the apical third of the clinical root. This creates areas of pressure and tension on the opposite side of the fulcrum. When jiggling forces occur, which is coming from different and opposite directions, cause more complex histological changes in the ligament. There are no distinct zones of pressure and tension. Again, I will repeat. First, we have first paragraph. I have said you have understood it very well, because jiggling force, intermittent forces in two different directions. Premature contacts on, for example, root filling causes widening of alveolus and increased mobility. This is very well known, and we have studied such things before. But we also have to add jiggling force. The second paragraph wasn't that clear. Under forces of occlusion, a tooth rotates around a fulcrum or axis of rotation, which is in single rooted tooth is located in the junction between the middle third and the apical third. So it is more than to the lower part of the tooth, between the middle and lower third of the tooth. This is the fulcrum of the tooth of the clinical root, and this creates areas of pressure and tension on the opposite side of the fulcrum. When this is the third paragraph, and I hope to make you understand this time. The jiggling force also occurs, which is coming from different and opposite directions, cause more complex histological change in the ligament, periodontal ligament. There are no distinct zones of pressure and tension. In jiggling force, there are no distinct areas, like in orthodontic movement. Again, jiggling force, intermittent. Jiggling force is between the fulcrum, is in the fulcrum between middle and apical third, and jiggling force has no distinct tension and pressure areas. Types of trauma from occlusion. There are many types of trauma from occlusion. They have the primary occlusal trauma and the secondary occlusal trauma. The tissue injury associated with trauma from occlusion is often divided into primary and secondary. Primary and secondary tissue injury from occlusion. The primary occlusal forces we are starting with today. The primary form includes a tissue reaction which is elicited around a tooth with normal height of periodontium. Examples include periodontal injury produced around teeth with a previously healthy periodontium, like a tooth that is very healthy, that's happening, that is undergoing primary occlusion for the first time, or the occlusal trauma for the first time. How to diagnose? Insert of high filling could cause this primary occlusion trauma, and insertion of prosthetic replacement that creates excessive force on the abutments and antagonistic teeth. So this is by increasing prosthetic replacement. Drifting movement or extrusion of teeth into spaces created by an replacement missing teeth. Also, of course, drifting could cause primary occlusion trauma. Insertion of prosthesis and insertion of high filling. Also, after drifting, we know that orthodontic movement of teeth also into functionally unacceptable position can cause occlusal primary trauma. The secondary occlusal trauma is related to a situation in which occlusal forces cause injury in periodontium of reduced height. So when this means someone asks me what is the meaning of the secondary occlusal trauma, I answered secondary occlusal trauma. The meaning is that the periodontium is not wasn't healed, or it was healed, but it wasn't in a very good and healthy shape. On the periodontium was in a reduced height. Number 3 type of trauma, we have the combined occlusive trauma, injury from an excessive occlusal force on a diseased periodontium. So it's not only a reduced height, but also a diseased periodontium. In this case, there is gingival inflammation, some pocket formation, and excessive occlusal forces are generally from parafunctional movements. This reduces the periodontium attachment areas and alters the leverage on the remaining tissues. The periodontium become more vulnerable to injury, and previously well-tolerated occlusal forces become traumatic. The distinction between a primary and secondary form of injury, primary and secondary occlusal trauma, serves no meaningful purposes, since the alterations which occur in the periodontium as a consequence of trauma from occlusal are similar and independent of the height of the target tissue. This means that it doesn't matter what is the type of trauma, if it's primary or secondary, because the height does not matter in this case, the height of the periodontium. An example, the periodontium. It is, however, important to understand that symptoms of trauma from occlusion may develop only in situations when the magnitude of the load elicited by occlusion is so high that the periodontium around the exposed tooth cannot properly withstand the distribute the resulting force with unaltered position and stability of the tooth involved. This means that in cases of severely reduced height of the periodontium, like in secondary trauma, the periodontium, even comparatively small forces may produce traumatic lesions or adaptive change in the periodontium, and I think this is happening in the secondary and combined occlusal trauma. Causing only small forces can cause irritation and can cause trauma lesions, adaptive change, and of course severe pain. Concepts of relationship between trauma from occlusion and periodontium disease. What is the concepts of relationship between trauma from occlusion and periodontium disease? So we have a Glickman concept that's saying that, formed by hypothesis that premature contact and excessive occlusal forces could be co-factor in the progression of the periodontium disease by changing the pathology and spread of inflammation into the deeper periodontium tissue. Glickman hypothesized that the gingival zone was zone-free irritation. By the microbial plaque, the super crystal fibers were then considered to be zone of the co-destruction under the influence of faulty occlusion. The Glickman said that the spaces when under occlusion we have more bone resorption or vertical bone resorption. The inflammatory lesion in the zone of irritation can, in teeth not subjected to trauma, propagate into the alveolar bone in the zone of irritation. Only in the zone of the irritation and trauma and subjected to trauma, propagate into the alveolar bone, open like they are open and they go deep. While in teeth subject to trauma from occlusion, the inflammation spread directly into the periodontium ligament, not to the bone. Very well, thank you Glickman for your concept. But we have the Werhog's concept is contradicting Glickman's concept, and he concluded, Werhog's
he concluded from his analysis that angular bony defects and infrabony pockets occur equally, not having occlusal trauma affect the magnitude and the ratio of angular and infrabony pockets, because they do not matter, as Werhog saying. They occur equally, often at the periodontal sides of the teeth, which are not affected by trauma from occlusion, as in traumatizing teeth. In other words, he refuted the hypothesis that trauma from occlusion played a role in the spread of gingival lesion into the zone of destruction. So he just said this, Warhogs. He said that he refuted or refused that the hypothesis that trauma from occlusion played a role in the spread of the gingival lesion into the zone of co-destruction. The gingival lesion meaning the bacteria that is going under the teeth. The loss of connective attachment and the resorption of bone around are, according to Warhogs, exclusively the result of inflammatory lesions associated with the subgingival plaque. Warhogs concluded that angular bony defects and infrabony pockets occur when the subgingival plaque of one tooth has reached a more apical level than the microbata on the neighboring tooth, and when the volume of the alveolar bone surrounding the roots is comparatively large. So the alveolar bone is comparatively large. Not about occlusal trauma. We take the two concepts in consideration. We don't. Warhogs and Glickman are both important concepts. Now we talk about stages of tissue response to temporary occlusal trauma. Stage 1 tissue injury, and stage 2 repair, and then stage 3 adaptive remodeling. Stage 1 to occlusal trauma. Trauma from occlusion or trauma from occlusion, we have tissue injury. Varying degrees of pressure tension creates varying degree of change. The areas of periodontium most susceptible to injury from excessive occlusal forces are the functional forcations between teeth. Most susceptible to excessive occlusal. Injury to the periodontium produce a temporary depression in the mitotic activity and the rate of the proliferation and differentiation of fibroblasts in collagen and in bone formation. These return to normal levels after dissipation of the forces. Dissipation of the forces. Again, I'll repeat, the stage 1, varying degrees of pressure and tension creates varying degree of change. The areas of periodontium most susceptible to injury from excessive occlusal forces are the forcations. Again, the second paragraph that I have read to you, I will repeat it again in order for you to understand. Injury to the periodontium produce a temporary depression in mitotic activity and the rate of proliferation and differentiation of fibroblasts in collagen and in bone formation. So we have differentiation, fibroblasts and collagen and bone formation. This return to normal levels after dissipation of the force. Very good. This is the first one, the first stage. Slight pressure we have causing resorption of the bone, widening periodontal ligament space, and blood vessels reduced in size. Slight pressure. With slight tension, periodontal ligament fibers elongate, opposition of bone and blood vessels enlarge. Now someone say, with a slight pressure, why do we see the blood vessels reduce in size? And is that dangerous? The answer is no, it's not very dangerous, and it is reversible. It could be dangerous on a micro level, and with very specific details and studying, people will notice something in research, but in real life we can say that it's this blood vessel reduction and periodontal ligament space widening and resorption of the bone is not that dangerous. And the other side, the tension side, of course this was the pressure side. The pressure side, we can see resorption of the bone because there is a pressure, there is widening of the periodontal ligament, there is blood vessel reduced inside. But the tension side, the tension we can say that the periodontal ligament has elongation of periodontal ligament, position of bone and blood vessels, enlargement. This is the slide, the tension side. Greater pressure causes compression of fibers, injury to fibroblasts, connective tissue cells, and necrosis of areas of ligament. Also, vascular change within 30 minutes. Impairment and stasis of blood flow occurs at 2 to 3 hours. Blood vessels appear to be packed with erythrocytes, which starts to fragment, and between 1 and 7 days, this disintegration of blood vessel walls, and release of contents into the surrounding tissues occur. In addition, increased resorption of the tooth surface occur. Again, increased resorption of tooth surface occur. In greater pressure, resorption of tooth surface, and disintegration of blood vessel walls, disintegration of blood vessel walls, and release of content into the surrounding. Release is its contact into the surrounding tissues, and blood vessels appear to be packed with erythrocytes. This all happening within 7 days of the compression of fibers and injury to the fibroblasts, with a greater pressure has been induced to the tooth, and resorption of the bone, of course, happening with greater. Also, this all we talked about only with greater pressure, but with greater tension, we can see the widening of periodontal ligaments, tearing of ligament, and resorption of alveolar bone, and hemorrhage and thrombosis. Again, with greater tension, we can see the widening of periodontal ligament, as we have seen before with the slight tension. With the slight tension, we have seen elongation of periodontal ligament, but here we can see the widening of periodontal ligament space, tearing of ligament, and resorption of alveolar bone. Unfortunately, tearing of ligament causes very difficult problems, because we all tear the periodontal ligament when we extract the tooth. And later, we can see that hemorrhage and thrombosis also occurs. Stage 2, repair. Repair is constantly occurring in the normal periodontal, and trauma from occlusion stimulates increased reparative activity. Any stimulus can increase reparative activity. Reparative activity includes formation of the new connective tissue cells. Fibers, bone, and cementum are formed to restore the injured periodontium. Also, forces remain traumatic only as long as the damage produced exceeds the reparative capacity of the tissue. Again, new connective tissue cells and fiber bonds and cementum are formed to restore the injured periodontium. Forces remain traumatic only as long as the damage produced exceeds the reparative capacity of the tissue. This is sometimes people ask, so why don't we see the tooth being badly resorption when we do orthodontic slight pressure and slight tension? The answer is simply because the amount of reparative in the teeth is equal to the amount of destruction or resorption of the teeth. Again, I will now continue. Thin bone is reinforced with new bone. Buttressing bone formation. So this is the reinforcement of the bone, which is either central buttressing restores the bony trabecula, or peripheral buttressing occurs in the facial and lingual surface of the alveolar plate. Peripheral, facial and lingual, and central occurring in the trabecula. Into the buttressing bone. Of course, central buttressing is on the trabecular bone, and the peripheral buttressing is on facial and lingual or palatal alveolar bone. Repair occurs as long as the reparative capacity exceeds traumatic forces. And the last stage is the adaptive remodeling. Forces exceed repair capacity. Periodontium is remodeled, an effort to create a structural relationship in which forces may or no longer be injurious to the tissue. This results in thickened periodontal ligament with no pocket formation and angular bone defects. Following remodeling, stabilization and resorption and formation occurs and return to normal. Following remodeling, stabilization of resorption and formation occurs and return to normal. The last stage, I will repeat this paragraph for you to hear it and understand. Forces exceed repair capacity. Periodontium is remodeled in an effort to create a structural relationship in which forces may no longer be injurious to the tissue. This results in thickened periodontial ligament with no pocket formation and angular bone. This means in the adaptive stage, we can see that the traumatic exceeds the reparative process, and therefore there will be a remodeling of the periodontal ligament. Remodeling will cause widening and cause reduction in the bone resorption, and the periodontial reduction in the caused by trauma. Let's read this one now. Reversible traumatic lesion. Of course, I will read it. You will only hear this as you can imagine. Reversible traumatic lesion. What is a reversible traumatic lesion? From this lecture, we can understand that trauma from occlusion is reversible, and the repair or remodeling occurs if the teeth can escape from force and periodontium adapts to force. Again, periodontium adapts to force and teeth can escape from force. This repair or remodeling occurs, and trauma from occlusion is reversible. Inflammation inhibits potential for bone regeneration. Inflammation must be eliminated. We have to eliminate to inhibit potential for bone regeneration. Inflammation inhibits potential for bone regeneration. So this is a question that comes to everyone, and everyone must answer this question. What is the thing, or what is the thing that inhibits bone regeneration? The answer is the thing that inhibits the bone regeneration is the inflammation. The thing that inhibits bone regeneration is inflammation. Moving on, clinical signs of trauma from occlusion. We have tooth mobility is one clinical sign of trauma from occlusion. Also, we have pain, fremitus, attrition, fracture, muscle joint pain. I will add from my ideas the pulpitis, periapical problem, and periapical abscess, cemental drops formation, etc. Starting with tooth mobility, occurs during injury stage, injured periodontal ligament fibers. I will say that it will happen during acute trauma. Also occurs during repair, remodeling, widening of periodontal ligaments. Tooth mobility regenerates then tooth mobility greater than normal, but not considered pathologic. I will repeat, tooth mobility occurs during injury stage and also occurs during repair modeling stage. Tooth mobility greater than normal, but not considered pathologic. So you don't have to worry about it. It's just greater than normal, but not pathologic. Also, we have sensitivity, fremitus, and pain. All these are clinical signs and symptoms of trauma from occlusion. Pain, fremitus, tooth migration, attrition, and muscle joint pain and fracture. Radiographic signs of trauma from occlusion. Now, what we see in the radiograph, we see change in the shape of periodontal ligament space, bone loss, thickened lamina dura, lateral aspect of the root, apical area and forcation area. We will see thickened lamina dura and vertical destruction of interdental septum. Again, vertical destruction of interdental septum. Also, we will see the root resorption hypersymptosis. When the root resorb, a hypersymptosis is formed. Vertical destruction of interdental septum. All we will see in the X-ray. Vertical destruction of interdental septum. And thickened lamina dura, or we will see the thickened lamina dura in the apical area, thickened lamina dura, forcation area, thickened lamina dura, and lateral aspect of the tooth, also thickened lamina dura. Diagnosis, history. Of course, we take history. Adequate history is of basic importance of any clinical diagnosis, and parafunctional habits must be recorded. Also, patient's psychic status must also be recorded. Parafunctional habits, status of the patient, adequate history, basic, important. Treatment outcomes proposed by AAP 1996, eliminate tooth mobility. This is treatment outcomes. We have to follow these guidance. Number 1, reduce or eliminate tooth mobility. Number 2, eliminate occlusal prematurity and firmitas, the sensitivity of the tooth. The firmitas is the sensitivity of the tooth. We have to know what is the meaning of firmitas. Firmitas is the sensitivity of the tooth. Again, what is the sensitivity of the tooth? Firmitas is the sensitivity of the tooth. After we eliminate firmitas and premature occlusion and eliminate tooth mobility, eliminate parafunctional habits, and prevent or eliminate tooth migration and decrease stabilized radiographic change. So maintenance, and we have to carefully observe and analyze the radiographic results. These are the treatment outcome. And of course, for primary occlusion is different from secondary occlusion, because the primary occlusion we have to do selective grinding, and the secondary occlusion also we have to do selective grinding. But in the primary occlusion we have to do habit control. This is a clinical treatment outcome, and clinically again selective grinding in both primary and secondary. Habit control, we don't do habit control in the secondary occlusal trauma, because in the secondary occlusal trauma it's already being controlled. And orthodontic movement, we can do it in the primary and secondary occlusal trauma. So in the primary and secondary occlusal trauma, we do orthodontic movement, we do selective grinding, and we do only habit control in the primary occlusion trauma, and only interocclusal appliance in the primary occlusal trauma. But in the secondary occlusion trauma, we do the splinting. So in the secondary occlusal trauma, there are only 3 things. 1 is special for it, that's splinting. 2 and 3 is general for primary and secondary occlusal trauma, that's selective grinding and not habit control. Habit control is the primary occlusal trauma. But after selective grinding, we do not also the appliance, orthodontic appliance. Actually, it is interocclusal appliance. It is very hard for the secondary occlusion trauma. Therefore, it's only used in the primary occlusion trauma. With the orthodontic movement, it can be distributed between primary and secondary occlusal trauma. Now, unsuccessful therapy. What is the meaning of unsuccessful therapy? Increased tooth mobility, progressive tooth migration continued, client discomfort, premature contact remained, no change in the radiographics worsening, parafunctional habits remain, anti-MG problem remain or worsen. These are all unsuccessful therapy prognosis. We can now study, and I will give you this information. Experiments carried out in humans as well as animals have produced convincing evidence that neither unilateral forces nor juggling forces applied to teeth with a healthy periodontium result in pocket formation or loss of connective tissue attachment. No pocket, no loss of connective tissue attachment. Trauma from occlusion cannot induce periodontal tissue breakdown. Again, trauma from occlusion cannot induce periodontal tissue breakdown. So it cannot induce periodontal tissue breakdown and cannot induce periodontal pocket formation or loss of connective tissue. Jogging for applied to teeth with a healthy periodontal experiment carried out in humans convincing evidence that neither unilateral force nor jogging forces applied to teeth with a healthy periodontium result in periodontal formation of loss of connective tissue attachment. So no pocket and no formation or loss of connective tissue attachment, fortunately, of course. And trauma from occlusion cannot induce periodontal tissue breakdown. So trauma and occlusion cannot induce periodontal tissue breakdown. And trauma from occlusion does not, however, result in resorption of the irregular bone, leading to an increased tooth mobility. Actually, trauma from occlusion does not, this time it does, however, result in resorption of irregular bone, leading to an increased tooth mobility, which can be of important and transient or permanent character, tooth mobility. And this bone resorption will resulting increased tooth mobility should be regarded as physiological adaptation of the periodontal ligament and surrounding regular bone into the traumatizing forces. An example to altered functional movement. So why do we see altered functional movement or tooth mobility? We can know that it is a response, physiological response to a trauma in the patient. In teeth with progressive plaque associated periodontal disease trauma, progressive plaque associated periodontal disease trauma from occlusion may, however, under certain conditions enhance the rate of progression of the disease, act as a cofactor in the destructive process. From a clinical point of view, this knowledge strengthens the demand for proper treatment of plaque-associated periodontal disease. In teeth with progressive plaque-associated periodontal disease, trauma from occlusion. So trauma from occlusion plus plaque-associated with periodontal disease can result. Both of these things under certain conditions enhance the rate of progression of the disease and act as a cofactor in the destruction process. This treatment will arrest the destruction of the periodontal tissue even if the occlusal trauma persists. So the treatment will arrest the destruction of the periodontal tissue even if the occlusal trauma persists. Next and last paragraph, I will read it to you and we have to understand it very well. A treatment directed towards the trauma alone, however, occlusal adjustment or splinting may reduce the mobility of the traumatized tissue and result in some regrowth of the bone, but it will not arrest the rate of further breakdown of the supporting apparatus caused by the plaque. So only treating it by the splinting is not enough because the plaque will continue its process of destruction of the bone. Thank you for listening to this lecture. And we have to reduce the mobility of the traumatizing tooth and result in some regrowth of the bone. Will not arrest the further breakdown of the supporting apparatus caused by the apparatus means the periodontal ligament, but we have to arrest the bone destruction. Thank you for listening to this lecture, and I hope you understood it.